All right, so we're going to discuss cutaneous lymphomas. In the first part, we're going to discuss B cell lymphomas. So looking at this long list of B cell disorders, we will cover reactive lymphoid hyperplasia, several types of primary cutaneous lymphomas, intravascular large B cell lymphoma, and some other more rare entities. So let's start out with reactive lymphoid hyperplasia. You can see the clinical image here on the right with some type of nodule in the lower ear. It can occur anywhere. Most often it's seen on the head and neck, trunk, and extremities. The variety of clinical scenarios include after some type of trauma, some type of tick bite. For example, Lyme disease and tick bite reactions are associated with this reactive lymphoid hyperplasia. You can see this in drug reactions, trauma, as I said, some viral infections, and even after vaccines. And of course, anything in dermatology can be idiopathic, meaning that we don't really understand a cause and effect with what stimulated the reactive lymphoid hyperplasia to begin with. It's a reaction pattern, and you have to exclude other more serious diagnoses. Some of those other exclusions that we'll talk about today are the other types of cutaneous lymphomas. So clinically, you'll see solitary small plaques and nodules with usually no ulceration, and most resolve after removal of the stimulus. So looking at the reactive lymphoid hyperplasia on the left and comparing it more to a neoplastic architecture on the right, with the reactive, you'll see more well-spaced lymphoid follicles with mantle zones generally well preserved. You may see frequent mitoses and tangible body macrophages, which we'll show you a picture of. The germinal centers are often polarized, meaning that there's some architecture that you can see that resemble normal lymphoid follicles. Looking to the right, you can see neoplastic often shows crowding of the neoplastic cells with back-to-back follicles, not as much organization as you see in the reactive. The mantle zones themselves are actually diminished or even absent. And counterintuitively, you're going to see less frequent mitoses. However, in high-grade situations, you may see more. And you'll also see less frequent tangible body macrophages. Here's a snapshot of reactive lymphoid hyperplasia. You can see this kind of polarity to the lymphoid follicle. And over here to the right, you see tangible body macrophages, which are essentially large macrophages that are taking up some smaller cellular debris. Here are images of kind of a well-organized architecture of a lymphoid follicle within lymphoid hyperplasia. So you can see CD10 is located within the center of the follicle, CD21 representing follicular meshwork or dendritic cells. The BCL6 is well contained within that architecture, and you can kind of see a correspondence with the CD21 follicular meshwork dendritic cells. And then BCL2 is on the outer rim typically, and those represent more of the marginal zone cells. Here's a little cartoon to show you how we can think about the origin of B cell lymphomas. So if you go to the center, you're thinking about germinal center derivation, and you can think about follicular lymphoma, Burkitt's lymphoma, or large cell lymphoma. And we'll talk about these specifically. Moving to the mantle zone, you can think about naive B cells, which contribute to the development of mantle cell lymphoma, and marginal zone, which you can think about memory B cell derivation, and that contributes to CLL and SLL, as well as marginal zone lymphomas. Another entity including plasma cell myeloma, you can have either cutaneous involvement by multiple myeloma or even a primary plasmacytoma. We'll talk about that entity as well. So let's start out with just a general tidbit of primary cutaneous B cell lymphomas. So they represent 25% of cutaneous lymphomas. They usually involve only the skin at presentation without involvement of other sites. So if it does involve other sites, then it becomes a question of, are we looking at cutaneous involvement by systemic lymphoma, or are we looking at systemic involvement by a cutaneous lymphoma that advanced? However, pure primary cutaneous B cell lymphomas, if you catch them without any systemic involvement, then that is kind of going to help you classify it as a primary cutaneous B cell lymphoma. Many times clinically, you're going to find involvement of the skin by systemic. So you really have to correlate clinically. 90% are of 3 different types. So we'll discuss follicular or primary cutaneous follicle center cell lymphoma, primary cutaneous marginal zone lymphoma, or primary cutaneous large B cell lymphoma. And I will refer you to the World Health Organization classification of tumors of hematopoietic and lymphoid tissues. Also, these articles down here in hematopathology by Dr. C and Dr. Jaffe as well. So let's start out with the discussion on primary cutaneous marginal zone lymphoma. So clinically, these can present as reddish-brown to violaceous papules, nodules, or plaques, solitary or clustered, in adults, usually greater than 40 years old. It can involve the trunk, arms, head, and neck. And you'll remember back to that cartoon, these represent typically post-germinal center memory B cells, often with plasmacytic differentiation. That's important because if you have enough plasma cells within the neoplasm, you can begin to think about a workup that you can stain for either kappa or lambda light chains. And so that becomes very important in demonstrating monotypic expression. Interestingly, these are associated with Borrelia burgdorferi in Europe. This has not been shown to be associated with Borrelia burgdorferi in the US studies, however. The prognosis, it's pretty indolent, 30% recur, and the 5-year overall survival rate is about 100%. So that's very, if you had to choose to have a primary cutaneous lymphoma, it'd probably be better to have a marginal zone lymphoma. So here you can see cutaneous marginal zone lymphoma, just kind of a snapshot picture. And I'm sure your eyes migrated to this beautiful grin zone at the top. B cell lymphomas often have a grin zone in contrast to T cell lymphomas. You can also see a diffuse infiltration of lymphocytes, which do not have any particular nodular or germinal center architecture. And you have the cells interweaving and dissecting and intercalating between collagen bundles. Just a higher power view to show you kind of the monotonous neoplastic or clonal B cell population in this marginal zone lymphoma. And this picture is just to highlight some of the plasmacytic differentiation that you can see in these tumors. So primary cutaneous marginal zone lymphoma can be worked up with immunohistochemistry. The most common positive stains include CD20, again, this marks B cells, BCL2, and CD79A in the plasmacytoid differentiated cells. You can have some aberrant CD43 expression. CD21, 23, or CD35 are often used to highlight follicular architecture. And if you have a less organized follicular architecture, that's going to be more supportive of a primary cutaneous marginal zone lymphoma. As I mentioned earlier, because of the plasmacytic differentiation that you can find, you'll be absolutely able to stain for kappa or lambda, looking for monotypic light chain expression. So if you see a nice mix of kappa and lambda within the plasma cells, it may not be as supportive of a cutaneous lymphoma. This is not referring to plasmacytomas, which are composed fully of plasma cells or neoplastic plasma cells, whether it be derived from multiple myeloma or a primary plasmacytoma. You can have some rare positivity for CD5. I usually don't rely on CD5 to make the diagnosis at all, because that's more indicative of mantle cell lymphoma, which we'll talk about, and can also be present in CLL. Most often, if you're looking at a molecular test, you're going to be able to identify clonal rearrangement of immunoglobulin heavy chains in most cases. So 7 out of 10 cases on average. Usually, immunohistochemical stains for CD10, CD23, BCL6, and cyclin D1 will be negative. If there are reactive follicles within the specimen itself, unrelated to the pure primary cutaneous marginal zone lymphoma, you may see some CD10 and BCL6 positivity within those reactive follicles. So it becomes important to kind of figure out within the specimen which parts you consider neoplastic and which parts may represent reactive. Again, the development of a clonal lymphoid process can cause some local trauma, and that local trauma can stimulate reactive lymphoid hyperplasia. So it can become pretty difficult. And in reality, you're going to have to become friends with your hematopathologist to be able to separate these out as well and have concurrence between dermatopathology and hematopathology. So here is a low power biopsy demonstrating diffuse, nodular, and even some interstitial expression of CD20 within the marginal zone lymphoma. You can see the CD10 is lacking any kind of meaningful nodular architecture. So this is an unorganized CD10 expression, which would argue for a cutaneous marginal zone lymphoma. BCL2 is expressed in the majority of the neoplastic population of B cells. Keep in mind that BCL2 can be expressed in normal T lymphocytes as well. So if you do a CD20 and a CD3 stain and you're noticing that the BCL2 is corresponding more with the T cell areas, then that's not going to be a valid association with the marginal zone. You need to really prove that the marginal zone lymphoma that you're working up is BCL2 positive. How can you tell primary cutaneous marginal zone lymphoma from a systemic lymphoma? So you can use immunohistochemistry morphology, as we talked about, but the problem is that primary and systemic can be identical. So the translocation 1118 may be positive in systemic lymphoma. Often, systemic lymphoma has IgM and IgD positivity, unlike primary cutaneous marginal zone lymphoma. You're going to have to correlate with the clinical information, the physical exam, the imaging to make sure that there is no systemic involvement. And if you do have both cutaneous and systemic involvement, it may be difficult in reality to ever figure out which came first. And we just have to be able to admit that sometimes we're not sure. Moving on to primary follicle center or follicular lymphoma, it's the most common type of primary cutaneous B-cell lymphoma. Occurs more often in males than females and usually in adults greater than 50. You have firm erythematous to violaceous plaques, nodules, and tumors. The majority are solitary lesions. This has a predilection for the head and neck, affects the scalp, trunk, and other sites. And it has to be limited to the skin to be called primary cutaneous follicular cell lymphoma. The prognosis is fairly good. So the recurrences are common, about 30%. And the 5-year overall survival rate is less than that of the marginal zone, which was at 100%. So this is 95%. So unfortunately, on average, over 5 years, one person would die out of 20. Clinically, it's somewhat nondescript, but it does have that deep purple to pink or violaceous nodular papillum coalescing in a plaque clinical presentation, as we see so often with our cutaneous lymphomas. Here is a relatively low power image showing, again, the grin zone on top and a very diffuse, pretty sheet-like growth pattern of lymphocytes. You can have dermal and subcutaneous infiltrate. Over the top, though, you're going to notice the grin zone more often than not in B-cell lymphomas, as I mentioned. With the marginal zone, the same thing with the follicular lymphoma. You can see irregularly shaped follicles without tingible body macrophages. And so, again, if you're seeing a lot of tingible body macrophages and you see well-organized follicles, then that's probably not going to be a follicle center cell lymphoma. On higher power, you'll start to see a mixture of different populations of small lymphocytes. Centrocytes are the neoplastic cells that have the small cleaved nucleus, and centroblasts are a little bit larger and they have the non-cleaved nuclei. You can see some kind of nucleolar or condensed DNA material within the nucleus. And so you can have a mixture of these cleaved centrocytes and the non-cleaved large centroblasts throughout. Another example of this, you can just see multiple populations here, some small nuclei with little indentations or cleaved areas, and then the larger centroblasts. So what about the immunohistochemical workup for primary follicle center lymphoma? You're going to look for CD20 positivity, of course, with B cells, but the key thing to remember is BCL6 positivity is going to be more helpful in looking at if this is a primary follicle center lymphoma or not. You can have variable CD10. The CD21 follicular dendritic meshwork can be negative in the diffuse pattern. Remember that the CD21 follicular dendritic meshwork in reactive lymphoid hyperplasia is going to be pretty well organized, and you're going to have the BCL6 positive cells contained within that follicular meshwork. However, in the primary follicle center lymphoma, you may not see or a very disorganized CD21, and mostly what you're going to see are these BCL6 positive cells present irrespective of where that CD21 is expressed. You may have light chain restriction, but in contrast to the marginal zone, this will not work if you have low plasma cell levels. So don't rely on the plasma cells when you're working these things up. In reality, you should be able to look at the actual B cells themselves as opposed to the plasmacytic differentiated cells, which are derived from B cells, obviously. They're producing antibodies. However, you may have very low levels of plasma cell differentiated cells within a follicle center lymphoma. Which stains are negative? So CD5 is negative usually. Cyclin D1 is usually negative. Those are the stains that you're going to be looking for mantle cell lymphoma. BCL2 is usually negative in the neoplastic cells. However, keep in mind that BCL2 can be expressed in many normal T cells. And in fact, it could be expressed in systemic involvement of a follicular lymphoma to the skin. So be careful with the BCL2. You might see it or you might not see it in follicle center lymphoma, but in a pure primary follicle center lymphoma, it's typically negative. If you have infiltrating T cells mixed within the population, you might see BCL2 there on those, as well as CD5. So try to correlate the populations that you're looking at and make sure that they're actually B cells. So this cartoon was shown to me in fellowship, and these slides were actually adapted from our fellowship lecture at the Cleveland Clinic. And I always remember this fishbowl analogy, which is very helpful. And so you'll imagine that the CD21 is the fishbowl. That marks follicular dendritic cells. The BCL6 marks centrocytes and centroblasts. And in reactive lymphoid hyperplasia, you can see that the BCL6 is pretty well contained within the CD21 area. However, in a follicular or primary follicular lymphoma, cutaneous lymphoma, you have really kind of unorganized or even loss of CD21 expression, and the BCL6 is present whether you have the CD21 there or not. And so these really angry piranha-like fish are jumping out of the bowl, the CD21 bowl, and these BCL6 piranha type fish are kind of invading the rest of the tissue. So that's how you can kind of remember that. So here you see the BCL6 expression. You can also see a lot of CD10 expression as well. And the CD10 expression, if it's high, it can make you think about potentially a systemic follicular cell lymphoma that's involving the skin. So we'll get to that. So how do you tell the primary follicle center lymphoma from cutaneous involvement? By systemic follicular lymphoma. The systemic origin will present with strong positivity for CD10 and BCL2. So there's a nice paper that looked at more than 50 patients. I believe it was in Spain, and they submit some pretty strong data that suggests that if you've got BCL6 positivity diffusely in the skin, and you've got diffuse CD10 as well as BCL2, that this could be indicative of a cutaneous involvement by a systemic follicular lymphoma. Now, of course, we need clinical correlation and even molecular and cytogenetic studies to help us. There is a nice molecular test to look for the translocation of T1418 or immunoglobulin heavy chain to BCL2 translocation. If there's a positive detection of this translocation, that favors involvement by the systemic lymphoma. Some cases of primary have shown the above translocation though, so it's not 100%. Cutaneous diffuse large B-cell lymphoma, leg type. This is probably the most memorable favorite cutaneous lymphoma that I learned when I was a first-year derm resident, because it seems so random to have a leg type of a diffuse cutaneous of a B-cell lymphoma. So this cutaneous diffuse large B-cell lymphoma leg type is usually present in older females greater than 70 years old. Often presents as multiple red or bluish red nodules, plaques, and subcutaneous tumors or ulcers. 10 to 15% of them are at a site different from the leg. And so that's kind of funny to think about, that you've got a leg type, however, it may not be present on the leg itself. So keep in mind that you can have this diffuse large B-cell lymphoma leg type, and it doesn't have to be on the leg. How are you going to figure that out? We'll talk about in a second. You can see expression on the trunk, the upper limbs, the head and neck. The treatment is essentially as if it is a systemic diffuse large B-cell lymphoma. So if it's only cutaneous involvement, there's no systemic involvement, you still have to treat it as if it's a systemic lymphoma of some sort. It can be pretty aggressive. The prognosis, unfortunately, relapses and extracutaneous dissemination is common. Frequent central nervous system involvement, and the 5-year survival rate, unfortunately, is only 50% on average. So here you see a diffuse sheet-like growth of large B cells, intermixed inflammatory cells from low power. You can tell that the lymphoid cells are quite large. On higher power, you can see enlarged nuclei with some condensed nucleoli, some irregularly shaped contours to the nuclei, diffuse sheet-like growth pattern. It's got a mixture of smaller cells and larger nuclei. So this is a very pleomorphic lymphoid population. And just by looking at it, you just know that you're gonna have to do some stains to really try to characterize this. Being able to recognize this on H&E, that this is a diffuse neoplastic lymphoid population, is going to be key for the beginners. So now that we've recognized we need to work it up, what are we going to stain it for? So of course, CD20 to prove that they are a B-cell origin. CD79A can be positive in some of the plasmacytic differentiated cells. BCL2 can be positive in these as well. MUM1 is the key stain that you're going to have to know associated with cutaneous diffuse large B-cell lymphoma leg type. And so that's the right answer for the exam. We will discuss, though, that there are some exceptions in real life, and you can have diffuse large B-cell lymphoma leg type that is not MUM1 positive, and we'll talk about why that is. FOXP1 can also be positive, and you can see diffuse positivity for BCL6 too. So this becomes very difficult when you start having BCL6 positive, MUM1 positive. I would say that if you've got MUM1 positive and histologically these are diffuse large B cells, then you're going to be able to feel more confident making the diagnosis of cutaneous diffuse large B-cell lymphoma leg type. However, while CD10 is usually negative, there are some rare cases of MUM1 negativity with diffuse large B-cell lymphoma as well. And that really comes about by looking at the overall histology, looking at the location clinically, and looking at the molecular results. So what molecular alteration is seen in cutaneous diffuse large B-cell lymphoma leg type? Gene expression studies have shown that these cells have an activated B-cell-like pattern. The cytogenetic abnormalities include MYC, BCL6, and immunoglobulin heavy chains with deletions in CDKN2A and CDKN2B. And there is a high incidence of this MYD88L265P mutation present in 40 to 69% of these cases. So my colleagues and I have actually had a case here, and we sent it out for consult with other dermatologists, dermatopathologists, and hematopathologists in Washington, D.C. to get an opinion on whether or not what we had that looked like a diffuse large B-cell lymphoma leg type, it was on the leg. However, it was MYD88L265P mutation positive, and it was MUM1 negative. So they agreed that this was most likely a diffuse large B-cell lymphoma leg type in this patient because of the MYD88L265P mutation, despite its MUM1 negativity. However, these cases can be pretty tricky. And as one of my mentors in Miami used to say, it is what you call it. So if you go back and do retrospective studies, you're never going to find 100% concurrence with any one set of immunohistochemical profiles or molecular studies, because if someone labeled something as such, then it may not fall into a category, whether it's true or not. So just keep in mind that these cases can be pretty difficult. But if you do have something that you're suspecting a diffuse large B-cell lymphoma leg type, that's important because the prognosis can be very poor. And that brings us kind of this next chart published in JAMA Dermatology, which looked at the primary cutaneous large B-cell lymphoma leg type cases that had a MYD88 wild type or a MYD88L265P mutation. And you can see that survival is much worse in the mutation group. So at the end of the day, doing the testing for MYD88 is more important than not. And of course, if you can't classify it, it becomes an NOS case. So cutaneous diffuse large B-cell lymphoma, not otherwise specified, are rare cases of diffuse large B-cell lymphoma arising in the skin. They're not categorized as either a leg type or a primary cutaneous follicle center lymphoma. They don't fit the definition of a T cell or histiocyte-rich large B-cell lymphoma or a plasmablastic lymphoma. They're typically restricted to lymphomas showing typical features of primary cutaneous diffuse large B-cell lymphoma. They typically lack BCL2 expression, and this is kind of thought of as a holding category diagnosis. And of course, with any aggressive type of lymphoma, you can have intravascular involvement. So thinking about intravascular large B-cell lymphoma, this often occurs in elderly adults. It's usually widespread at presentation, and it can affect the skin as well as the central nervous system, the lungs, the GI tract, the kidney as well. These patients, as so often with systemic involvement by a malignancy, have B symptoms. They can have high LDH, high ESR. Clinically, you'll see violaceous or erythematous plaques and nodules. And unfortunately, this is aggressive disease with a 3-year survival rate of 56%. So from low power on the top left, you can see some type of aggregation of lymphoid cells within the lumen of a vessel. And on higher power, you can really appreciate the aggregation with some single dispersed cells throughout the lumen. Intravascular large B-cell lymphoma can be worked up immunohistochemically. You're going to look for positive CD19 and 20, which mark the B cells. You can see some CD22 positivity as well as CD79A positivity, depending on the plasmacytic differentiation. And you can see BCL2 positivity as well. These are often negative for CD5, CD10, and BCL6. Moving on to an entity known as lymphomatoid granulomatosis. This is an entity that is known to be angioinvasive as well as angiodestructive. It can occur at any age, but usually it peaks at the 40s to 60s demographic, typically males greater than females. Lung involvement is present in 90%. The skin involvement is present in 25 to 50% of patients, with brain, kidneys, and liver involvement as well. These often occur in immunosuppressed patients. And what virus is typically associated with this? I'll let you think about it. So if you guessed Epstein-Barr virus, you're correct. So here is an example showing the lymphomatoid granulomatosis. This is from Web Pathology. And you can see this angiocentric and angioinvasive neoplastic growth pattern of the lymphoid infiltrate. There's actual transmural infiltration of the walls of various blood vessels by these mononuclear cells. And you can see this is actually from lung, but it shows the lung parenchyma, which has some areas of necrosis. Another example of this very transmural migration of the monocytic cells with areas of necrosis, areas of almost looks to be angioinvasive, but also forming small intraluminal thrombi from the destruction process of the vasculitic type behavior of these cells. Lymphomatoid granulomatosis usually shows positivity for CD10 and 79A in the large atypical B cells. CD30 is often positive in the large atypical B cells. And because of the association with EBV, EBR-CISH, or in situ hybridization of the EBV virus, nucleic acid is usually positive. Negative stains often include CD15, CD56, and CD57. And you can definitely have a background T cell population within this process. So what other cutaneous lymphoma is EBV positive and angiodestructive? Extranodal NKT cell lymphoma, which we'll discuss in the next lecture on T cell lymphomas. Chronic lymphocytic leukemia, small lymphocytic leukemia. This is present usually in males greater than females over 60 years old with elevated white blood cell counts, usually greater than 5 billion per liter. These patients present with lymphadenopathy. You can see skin involvement in rare cases. Rarely, it's a presenting symptom, about 15%. You can see papules, nodules, tumors, or plaques, erythroderma or bullous lesions. And the lesions can localize to site of previous herpes infection, interestingly. So again, this looks like your normal B cell process because you've got a nice grin zone, but you see this sheet-like diffuse dense infiltration of lymphoid cells. This is an example of CLL or SLL. On higher power, you see the very monotonous morphologic appearance to these cells, very sheet-like growth, also kind of intercalating between collagen bundles and essentially destroying any dermal architecture. It's so diffuse. What type of workup are you going to do for immunohistochemistry? You can do CD5, that's going to be positive in most of these cells, as well as CD20, CD23, and BCL2. And this entity is typically negative for CD10, BCL6, cyclin D1, and SOX. The CLL, SLL molecular profile, interestingly, if you have a deletion in 13q, that's associated with a good prognosis. However, deletions of 11q22, 17p, and 6q are associated with a poor prognosis. There's another type of CLL, SLL that shows trisomy 12, and that's no change in the prognosis. Moving on to mantle cell lymphoma. This occurs in older adults. They present with generalized lymphadenopathy, most frequent at presentation, but they can also have involvement of the bone, the spleen, the liver, the GI tract. There's an entity called lymphomatosis or lymphomatous polyposis of the intestine, and that's usually the mantle cell involvement in the GI tract. Of course, peripheral blood can be involved. These patients can have B symptoms with weight loss, fever, night sweat in 14 to 50% of cases. Cutaneous involvement is exceptional. Most consistent prognostic indicator is high mitotic index, and they can show a blastoid or pleomorphic morphology. Unfortunately, mantle cell lymphoma has a bad prognosis with median survival of 3 to 5 years. Mantle cell lymphoma. This picture shows a nodular diffuse architecture to the neoplastic cells with hyalinized blood vessels. And the stains for mantle cell lymphoma, as I mentioned earlier in the talk, include CD5, CD20, cyclin D1, and SOX11. Mantle cell lymphoma is usually negative for CD10 and CD23. So for your exam purposes, definitely focus on CD5 and CD20 because that proves that you're looking at B cells that are CD5 positive. Remember, CD5 can be expressed in normal T cells. So you need to make sure that you're looking at B cells that have CD5 positivity. And of course, mantle cell can overexpress the cyclin D1, which becomes useful because there is a molecular test to look at the translocation, assessing for cyclin D1 expression. So you can see the diffuse expression of cyclin D1 in mantle cell lymphoma as indicated in this example. And what is the characteristic translocation of the mantle cell lymphoma? As I mentioned, you're going to have this translocation 1114, Q13, Q32, which is the cyclin D1 or CCND1 immunoglobulin heavy chain rearrangement. Moving on to Burkitt lymphoma. So Burkitt lymphoma is very striking, as you can see in this picture on the right. There are three variants: the African endemic Burkitt's lymphoma, which presents as a jaw mass in a child and has a strong association with Epstein-Barr virus. There's the Western or sporadic Burkitt's lymphoma, which shows nodal or extranodal sites, often intra-abdominal. It's not typically associated with EBV. It can affect children and young adults. And then Burkitt-like lymphoma, which presents nodally in immunocompromised hosts. Cutaneous involvement is rare. So Burkitt lymphoma has this starry night appearance. They say stars in the dark sky, as you can see here, with these tingible body macrophages separated throughout the neoplastic cells. So the neoplastic cells are usually molded against each other. They have these kind of very squared off borders because they're smushed together and they're kind of changing the contours of the nuclei. When you hear molding against each other, you often also think of an entity of Merkel cell carcinoma, but it has a similar appearance, right? So if you see this molded against each other morphology, and you know you're not looking at some type of Merkel cell, then you can be thinking about the Burkitt's lymphoma. There's often gaps between the neoplastic cells secondary to retracted cytoplasm. The nuclei are often round with finely clumped chromatin and several paracentral nucleoli. They often have a high proliferation rate with numerous mitotic figures and apoptotic bodies. The plasmacytoid differentiation, as well as the myopleomorphism possible in immunodeficiency-related Burkitt lymphoma. So if you're seeing the Burkitt lymphoma type pattern and the patient's immunodeficient, you may actually see quite a bit of plasmacytoid differentiation. As I mentioned, tingible body macrophages, which we often associate as being present in reactive lymphoid hyperplasia, but not present in the cutaneous lymphomas, you can see tingible body macrophages in this entity. And so these are macrophages, again, as I said, taking up apoptotic debris. That's the tingible bodies. And these are the stars in the scattered sheet of neoplastic cells, or the dark sky. No histologic grading is typically present for these entities. So Burkitt cell lymphoma immunohistochemical stain workup includes, again, CD20 for your B cell workup. CD10 can also be positive, as well as BCL6, c-Myc, and very high Ki67. Again, these cells are proliferating very drastically, and so Ki67 index will be high. Usually, Burkitt cell lymphoma is negative for BCL2 and TDT. The molecular, you got to think about what translocation is seen in Burkitt. That's the Myc translocation, by definition, is always present. So you can also think about the c-Myc being expressed at high levels, usually involving the immunoglobulin heavy chain, or T814, Q24, Q32. Moving on to B lymphoblastic lymphoma. This is the most common malignancy in children. It peaks at 3 years. Lymph nodes, central nervous system, liver, spleen, and testes can be involved, rarely the skin. However, it can. The risk factors for B lymphoblastic lymphoma include Down syndrome, Fanconi anemia, Li-Fraumeni syndrome, ataxia telangiectasia, and Bloom syndrome. You see these large blastic cells within the B lymphoblastic lymphoma. You can see how much larger they are than the erythrocytes. B lymphoblastic lymphoma immunohistochemical workup includes positivity for CD19. And interestingly, CD20 can be rather dim. The CD19 is usually more positive in this entity, as well as CD10, PAX5, CD34, CD99, HLA-DR, and nuclear TDT. So B lymphoblastic lymphoma, if you're working this up, in my career, we've used the PAX5 as well as the TDT to really kind of assess whether or not patients have skin involvement by the lymphoblastic lymphoma. It's very rare, but you can see cutaneous involvement by acute lymphoblastic leukemia, and that kind of becomes a lymphoblastic lymphoma. It can be rather confusing if the patient started out with leukemia first rather than lymphoma. And so you really have to get a detailed history into the peripheral blood flow cytometry, whether or not they had the presence of abnormal leukemic cells first, or whether they only had lymphoma, and close detailed chart review with the oncologic data that you have, as well as flow cytometry and consult with hematopathology, are going to be critical to understanding if you've got skin involvement by a B lymphoblastic lymphoma. These are typically negative for CD45, and like I said, CD20 is dim or absent. So being negative for CD45 suggests that they have not acquired that mature leukocyte marker of CD45 yet. So the less differentiated hematopoietic cells lacking CD45 suggests a poorly differentiated, more primitive cell state. Moving on to cutaneous manifestations of myeloma and primary cutaneous plasmacytoma. As I said, you can have secondary cutaneous involvement in a patient with multiple myeloma. I've seen this most in my career so far. We've had patients with known multiple myeloma that develop these nodules, and were consulted as dermatologists and dermatopathologists to obtain a biopsy and rule out plasmacytoma. So secondary cutaneous involvement in patients with multiple myeloma is more common in patients that have IgA and IgD expressing tumors, often direct extension from the bone marrow infiltrate. This has a very poor prognosis to have skin involvement, and most patients unfortunately die within 6 months. Primary cutaneous plasmacytoma is most often found in the upper respiratory tract. It's very exceedingly rare in the skin. So here you see a biopsy showing diffuse infiltration of plasma cells. You can tell the nuclei have that clock face, condensed nucleoli in many of the nuclei, but you also have this eccentric eosinophilic cytoplasm with this more darkening purple rim to the outside. And so you know you're looking at plasma cells. Of course, if you want to prove immunohistochemically that you're looking at plasma cells, you can do a CD38 stain, a CD79A, or a CD138 stain. You'll also want to look for monotypic light chain expression, so doing stains for kappa or lambda, just to look and see if they're primarily expressing either one or the other. And in the plasmacytomas that I've had, it's been beautiful that when you actually stain for the light chains, it might either be all kappa or all lambda. And it's a very binary state. And so it's very nice to see that. Many things in dermatopathology are usually gray areas or borderline, but this is one of those cases. I've seen plasmacytomas that are very restricted to which light chain they're expressing. So it's always nice to see that. These are often negative for CD20 and CD45. And so we'll finish up with that topic. And for the next lecture, we will upload, it'll be a discussion on T-cell lymphomas. Thank you for your attention.